Hey, on behalf of India Health Fund, FIND, and Empower School of Health, I welcome all of you, all the esteemed speakers and panelists, and the participants to today's webinar on the role of new technologies in acceleration towards the elimination of tuberculosis in India. Today's webinar is the first in the series in the role of novel tools in improving healthcare outcomes. And this time our focus is exclusively on tuberculosis. As we know, and reports show that globally 10 million people have suffered from tuberculosis in the last few years, and the estimated deaths have been about 1.5 million. And if we come to India, we have nearly 2 million cases as on 2020 and nearly 500,000 deaths annually. India also set an ambitious goal of eliminating tuberculosis by 2025. And with only 3 years remaining to achieve this goal, it definitely calls for all players in this field to come together. We saw how the pandemic reversed some of the critical gains made before pandemic. However, all those gains, a lot of those gains were reversed, right from testing to treatment. And therefore, it has become imperative for all of us to find the way forward in addressing some of these gaps and losses. We did see how testing dropped, diagnosis and testing dropped somewhere between 38 to 45% across the country in 2020. While in 2021, we did see about 13% rise in the tests, but it was still about 23% less than the pre-pandemic times. Anyway, I'm not here to throw numbers at all of you, but it does bring to the core point that TB diagnosis and detection did take a huge beating. And therefore, there is a need for all of us to come together and address the challenge. And today's webinar is largely going to focus on the role of new technologies to contribute towards increasing an acceleration of more testing and diagnosis right from the grassroots upward. So we will be talking about the urgency and plan for action today. I'm going to now request Mr. Madhav Joshi, CEO of India Health Fund, to welcome everyone and set the context for today's webinar. Over to you, Madhav.
Thank you, Jaita, and good afternoon, everybody. Again, on behalf of India Health Fund and our partners FIND in the Empower School of Public Health, I'd like to welcome everybody to this session today. As you know, India Health Fund was set up as a partnership between the Tata Trust and the Global Fund, with the express aim of identifying promising technologies which needed support to go from lab to market. And our focus is really on facilitating this journey by de-risking the development of these technologies, and then working in very close collaboration with partners and stakeholders to not just support the evidence that these solutions need to scale, but also actively to play an active role in the scaling of these solutions. It's been a great ride so far. And I think we've been working with a number of our partners and collaborators towards this. And today's discussion is really to bring together perspectives from a number of our partners who are represented here, to share not just their experiences, but also perspectives on how technologies supported by India Health Fund have really fared in the public health system, and to also bring together thoughts on what needs to now be done to facilitate more collaborative action towards the scaling of not just these solutions, but other promising technologies to really help achieve the goal of elimination of tuberculosis by 2025, which is also in the context of a rising number of other infectious diseases which are playing out concurrently. So with that, I'd like to once again welcome all of our panelists and speakers and look forward to a very engaging session today. Thank you very much.
Thank you, Madhav. So I take this opportunity now to welcome all of you to the opening note, which is on the landscape of TB detection and diagnostics in India. Dr. Nishant Kumar from Central TB Division, Ministry of Health and Family Welfare, Government of India, is here with us to share the landscape of TB diagnostics and the priorities. Dr. Major Nishant Kumar is the Joint Director, Public Health at the Central TB Division in the Ministry of Health and Family Welfare and Government of India. He has served as public health specialist in IDSP at the National Center for Disease Control, New Delhi. He has experience of teaching in undergraduate and postgraduate students of medical school, and he has also served as the medical officer in the armed forces. I would like to welcome you, Dr. Nishant, to give us the overview of the priorities and the need for technology-led innovations for TB screening and diagnosis in India in view of the 2025 elimination plan. Over to you, Dr. Nishant.
Yeah, thank you. If you can just raise your hand if I'm audible, give me a sign that, okay, great. Thank you, Jeta, and I thank all the organizers, Mr. Madhav Joshi, Professor Paul, Madhukar Pai, Sanjay Sareen, yourself, Jeta, Dr. Mangla, Dr. Santosh Gupta, who's STO Uttar Pradesh, will be presenting today, who's in the panel. So I saw Dr. Chandni Nair also. So good afternoon and good morning to Dr. Pai. So thank you so much for giving me this opportunity and putting me in on spot to set the ball rolling. And I will request somebody from your side to put my slides. Yeah. So today I'll be discussing on the technologies that are available for diagnosis of TB as well as for detection of DRTB, adoption of the same by the program, Indian National TB Elimination Program, and the need to fulfill the ambitious goal which we have to end TB by 2025, 5 years ahead of the global target. If you can put it on slideshow mode, or is it okay? I can go ahead.
Tushar, can you please put this on slideshow? It would be helpful.
Yeah, thank you. Thank you so much. So we all are aware that to achieve TB globally, by 2030, we have to decrease the incidence of TB to less than 10% per year till 2025, and then the reduction by 5% yearly to achieve the target which we have in mind, that is 44 per lakh. It can be done. And I'll show in my slides that the way we were going in 2019, 2 years after implementation of National Strategic Plan, we were really on the right path. And that will be in my subsequent slide. So what the short point is, the curve can be bent with optimal use of current and emerging diagnostic tools by national TB programs, and also to have a universal health coverage. I mean, that also has to go side by side. To further reduce the incidence of drug sensitive and drug resistant TB, the diagnosis has to be completed with introduction of new tools, rightly placed, whatever they are there in the algorithm for maximal output, diagnostic modalities that can taken up to level 0. That is, I mean, this is the ultimate aim of a program manager, to have something which can be taken to the patient by the bedside. If we talk about point of care tests, I mean, that is the ambition, which that is the ask which any program manager would like to have, and that's what I would like to request. I mean, then to the researchers who are there today in today's webinar. And further, what can be done is incidence reduction can be accelerated by introduction of TB vaccines. It's high time that we should work on TB vaccine and novel treatment regimens. Recently, WHO has issued the shorter regimen guidelines for active and incipient TB. This all has to be done in addition to what we are doing right now and all the national TB programs across the world. So what I wanted to highlight, that despite COVID, we could with strong resilient mechanism which we have in place under the NTP lab network, we could notify 21.24 lakh cases 2021. As I said earlier, in 2019, we reduced this gap of missing million, as was happening in India's TB program, to less than 0.4 million. We could notify 24 lakh patients in 2019, and had COVID not come, we would have definitely achieved what were our targets. And I'll show in my subsequent slides what we talked about, how do we do it year wise as per the NSP plan. Next slide, please. Can we go to the next slide? Yeah. So over a period of 140 years now, we have come a long way. It all started with a microscope, and as the topic given to me is landscape, TB landscape, TB lab network landscape for India. So I'll just restrict myself to just to explain that whatever new technology which has come, the program has been forward enough to accept it, validated it in the country, and the latest guidelines, latest equipment which has been endorsed has been incorporated in the program. So over the years, whatever newer technology has been introduced, and with sufficient evidence, the program has taken it into its stride. And and it's not an easy job to for a country like us to have this kind of a network, but still we have. So this is journey so far as a whole for TB diagnostics, and the short point is that the NTP India has actually incorporated all possible innovations which came with sufficient evidence as soon as they came. TrueNat was actually the latest one to add to the arsenal, which was almost, I won't call it a point of care test, but yes, a technology which can be taken to field up to block level, maybe PHC in future very soon. So this is what I wanted to share through this slide. Next slide, please. Can we go to the case finding slide? So by the time the slides are coming up, yeah. So this is one slide which talks. No, go back, please. As I said, for 40 years after national TB program which was launched in 1962, when the approach was passive based on people coming with symptoms to the health facility. After 40 years, when RNTCP was being launched, the new intensified case finding effort was taken by adding the comorbid patients and making engagement, and it was quite one is also being done. And then in 2017, when we launched the NSP, we went a step ahead. Okay, this was a selected group where the chances of getting TB patient TB notification was more, but then now to identifying the vulnerable population in limited geography, and then going there with catch them early. In addition to earlier approach of just screening the household contacts of existing TB patient, then identifying the vulnerable population, just to give an example, migrant population, slums, prisons, or other congregate settings, and then going for with tools like mobile vans with the TrueNat and mobile vans with the X-ray machines. So, or getting getting the patients back to the facility to check them. So we went a step ahead, and now that was initial learning from 2017 active case finding effort. That now after identifying a population, it's not just one-time screening. The advisories are given to the state that they go and do this. They identify the vulnerable population in their geographies, and then with the latest tools, test them at a quarterly basis, and periodic screening is institutionalized. This is what the program is being implementing as finding the cases early, just to have a dent on transmission of the infection. Next slide. Now, and the system and the protocols are in place after finding the patients, putting them on the right treatment based on the diagnostic algorithm. As you can see in the algorithm, which is on the left side, that now we are replacing microscopy wherever NATs are there. So we have saturated about 50% of our blocks, that is the TUs, where NAT facility is there. And in this year, by end of 2022, looking forward 6,000 blocks. So the ultimate aim is to have 8,000 NAT facilities to realize the goal of NTB. And as per the NSP calculation, so by this year end, we are planning to reach up to 6,000 NAT. So short point is that now microscopy is being NAT is being offered as the first test wherever it is available at the right time to address the issue of latent TB. So this is going side by side with the help of the field level staff, that is Health and Wellness Center, to assess the risk groups for symptom screening and put them on the right TPT. Next. Yeah. So as you can see that ours is really proud of having the largest TB lab network in the world from 2017. If I can show you from 15, it would be really very steep, line. But then this is how the three-tiered, laboratory network is there. We have 6 national reference laboratories. They are all geographically, representing to cover the states in all the regions. We have NITRD Delhi, we have Jalma, we have BMHRC Bhopal, then NTI Bangalore, and IRT Chennai in south, and RMRC Bhubaneswar in down east. So that's what, and then we have about 34 IRLs and 58 culture DST laboratories which provide services ranging from, they have everything from microscopy till liquid culture DST. And then at district level, we have saturated all the district level with the NAT, and now we are going below district level also, and the number of DMCs are more than 22,000 plus. Next. So by the time next slide is coming, as far the infrastructure goes, we are going as per the NSP plan. Okay, so basically, what are some goals which are shown here on this slide? To reach incidence of 44 lakh per population. So we are focusing on these areas, finding TB patients early, treating them correctly to prevent emergence of drug resistance, improving and expanding the TB and DRTB testing, building capacity for continuous, and so that the workflow in the laboratories is smooth, and the outcomes are favorable, desirable. So we are establishing the laboratory management information systems in about 48 of our laboratories. And also, we are working on the preventing emergence of TB and addressing the issue of LTBI, and increase the age group to be offered TPT from all adult household contacts. So side by side, that is also going. Next. So in the next couple of slides, I would like to basically showcase what was, yeah. So this is a written document. It is a costed, budgeted plan, well-written plan, which specifically kept only the diagnostic part of it. So use high efficiency diagnostic tools for early and accurate diagnosis linked treatment across the country. Upfront rapid molecular testing. So you can see a row, and you can see the target of number of molecular laboratories we were supposed to set to realize, to offer NAT as upfront test, for diagnosing TB. So as I said, till 2019 we are really going as per the plan, and by 2021 we could have about 4,000 plus NAT. We were short of 2,000, but you all are aware why. Because 2020 we were affected. I mean the whole world was affected by, and everything went into a spin. Be it procurement, be it our laboratories being sucked into COVID response. But still, we are on the right course. As I said, by this year end, we are very hopeful to I know 6,000 plus NAT tests. In spite of COVID, the right path, and the targets are very much in sight, and with extra effort, definitely by 2023 we'll have this under control, that we have NATs across all the peripheral sites, which contributes. I mean, the idea of these 8,000 was 8,000 DMCs were giving us more than 80% of the notification or the diagnosis. So the plan was to saturate these facilities with NAT. So that plan is very much in place. Next. So next slide will talk about the numbers. I mean, in terms of numbers, it's not just having the infrastructure in place, but the way we have gone and conducted, and this is expansion of diagnostic infrastructure basically. So you can see that we have increased our DMCs. And there were 16,000 about total NATs. You can see that close to 4,000. The breakup of CB TrueNAT was introduced in 2019, and you can see the expansion, and 900 more are in pipeline. I mean, it is approved in the budget, and the states have to procure themselves. So that will add to the platforms, and you can see the increase in the infrastructure of LP and LCTST. Next. So this is something we are really proud of. If you focus on 2019, the way we were going, I mean, we did about, if you add CPNAT and TrueNAT was just added, but still we did 37.3 lakh NAT test. And then, in spite of COVID, if you see, we could 2021 we were hit the most, and everything went. I mean, the whole of infrastructure was challenged. We could do things were pressed into COVID, and that's what was natural. It was a resource and used. We are proud of that our lab responded to.
Dr. Nishant, we lost you.
Where did you? Which one do you want me to repeat? Where did you lost?
Just the last 15 seconds.
Okay, so I'll repeat again. So as you can see, the number of tests being done and the proportion of NAT for diagnosing TB is increasing, bound to increase. In 2020, when it was 20%. And
Dr. Nishant, it may be better if you switch off your video and just use audio.
slowly, as we get more to this, I mean, is it better now?
Yes, definitely.
Yeah. So, okay, my apologies. Yeah, we have just moved into a new building and connection issues are there. So I think it is what I was saying is very, very self-explanatory here, that slowly we are moving towards NAT as a first test, and the numbers of FLLP, SLLPA were going in the right direction till 2019. But then we were hit, and again we are back on track. So this is in a nutshell the infrastructure, the vision, and where we are as per that vision. And the last slide talks about the ultimate, wish list for a program manager for for TB. That ultimate aim and the request from researcher is to get something which we actually can take it to the patient's bedside. I mean, till now in TrueNat, we have reached, say, peripheral health facility up to, say, CHC or PHC. But I mean, if it's on my wish list, I mean, something which can be developed, which can be done, because we have seen whatever we try from every health facility, when we refer, even for, say, sample is transferred, I mean, there is some amount of loss. So if something can come as a tool which can actually be performed at the sub-center level or patient's bedside, I mean, that is something which is because I was asked to for my wish list, what could be the next step. Whatever is there available, the program is using to best of its capability and trying to use all the technologies optimally. And yeah, so this is, in the interest of time, I'll stop here.
Thank you. Thank you, Dr. Nishant. I think you made some very important points. You did highlight on quite a few issues, and thank you definitely for sharing the wish list, which actually is very, very critical. You did emphasize on bedside solutions, which is very critical. We also took note of the fact that you emphasized on optimization. You talked about self-testing. You also made a very important point on how microscopy is gradually being replaced by more and more NAT tests. And you've shared some of the numbers related to that, but you have also helped us as a collective of organizations here to understand exactly how CTD is envisaging the way forward in terms of testing. Thanks for giving us that overview. And we definitely look forward to working with CTD and engaging with you to see how we could support in terms of, number one, identifying more and more relevant, appropriate, and affordable innovations, which could help actually the decentralization, and also in terms of taking innovations to the last mile, to the sub-center, to the patients, for sure, to their bedside. I think that point is absolutely noted, and I'm sure your presentation is going to pave way for the next panel, which is going to look at the very, very important area of the need for innovations in screening, early diagnosis, and treatment initiation, given that the official from Central TB Division has laid out the current status, the overview, and the way forward in terms of their wish list. I think the next panel can address how this can be done in different ways. So thank you, Dr. Nishant. Thanks a lot. Please stay on if you can. We would really appreciate and be engaged in this conversation, and we will, in any case, continue to engage with Central TB Division. I would now like to request Dr. Shikha Dhawan to moderate the next panel, Dr. Shikha is an advisor to Empower School of Health, and she's director of programs at Share India. She has earlier been a consultant to Central TV Division and helped in scaling up diagnostics in India. She has 20 years of rich experience of working across infectious diseases at national and international level. Dr. Shikha, thank you for joining us, and over to you to take the next session forward, which is on the need for innovations in screening, early diagnosis, and treatment initiation for tackling TB. Over to you.
Thank you so much, Jaita, for the introduction and the kind invite to moderate the session. Now, as Jaita summed up, based on Dr. Nishant's presentation, we could see programs progress towards TB elimination by using innovative screening and diagnostic tools. And with that background, we are moving towards our next panel, which is on innovations in screening, early diagnosis, and treatment initiation to tackle TB, so that we can have a blueprint to accelerate our progress towards TB elimination in India. Now, I have with me today a distinguished panel of experts. To introduce the panel, we have today with us Professor Madhukar Pai. He's a Canada Research Chair in Epidemiology and Global Health at McGill University, Canada. He is the Associate Director of the McGill International TB Center and Editor-in-Chief PLOS Global Public Health. Welcome, Professor Madhukar. We also have today with us Dr. Sanjay Sareen, who is Vice President, Access and Country Programs at FIND, providing leadership for operations across FIND's country offices. Dr. Sanjay currently serves on the TB GLC for WHO CRO, the Lab Technical Working Group for National AIDS Control Organization, and Global Fund's COVID Technical Advisory Group. Welcome, Dr. Sareen. We have with us today Dr. Kayla Larson. She is the Gates Foundation India Country Office Deputy Director for Infectious Diseases and Vaccine Delivery. Her focus area includes TB, visceral leishmania, lymphatic filariasis, and vaccine delivery. Since March, she has been leading the COVID-19 response for the India BMGF office. A very warm welcome to you, Dr. Kayla. We also have with us today Professor Paul Lalwani. He is the founder and director of the Empower School of Health and the Center for Digital Learning. He has more than 25 years of experience in public health, capacity building, strategic planning, policy development, national and international partnerships. It's an honor and privilege to have all of you with us today. And before I move on to the panel discussion, some housekeeping instruction. We invite our esteemed audience to please pose their question in the QA box. And they may also kindly mention if the question is directed to a specific expert, and we'll take these questions at the end of the panel discussion. Now, I invite Professor Pai to tell us more about the urgency of TB diagnosis and novel tools to meet the SDGs 2030 and 2025 TB elimination goals in India. Over to you, Professor Pai.
Thank you, Shikha, and good evening, everyone. Thanks for having me. It's great to follow Dr. Nishant because we get to understand what India is doing and what COVID has done. So I think there is no doubt that even before COVID pandemic, case finding was the weakest link in TB. If you look at TB cascades of care globally in India and in other countries, the biggest drop off happens at the diagnostic stage. Once people are diagnosed, generally most countries are able to do a reasonable job on getting people on treatment and following them up. But the detection gap is the worst. And the detection gap, as we know, globally has increased from 3 million missing patients to 4 million missing patients during the COVID pandemic. We have lost about 20% of notifications globally because of this crisis. So to me, getting case detection back to where it was at least would be the most pressing priority for all of us in TB. Now, the question is, how do we do that? I just have a few ideas and thoughts that we can all discuss. One is we saw how wonderfully COVID data has been reported by all countries, states, districts. why could we not find a way to digitize TB data and have them available as real-time dashboards, as real-time as feasible, because greater visibility of TB numbers rather than once in a year annual reports will be immensely helpful, I think, for all of us, because if we can see some district is dramatically under testing for TB, then we can invest more resources in focusing on that district or block. Second is active case finding. I think we all agree that just passively waiting for people to show up in clinics has a role, but it can only go so far. We will not find all of the people missing unless we manage to reach them. And how do we do it? I think the only technology we have right now, which is immediately usable, is mobile digital X-rays or ultra portable digital X-rays combined with artificial intelligence solutions. And I think that's an innovation which looks like it's really matured a lot. We have several AI solutions endorsed by WHO, really nice ultra portable X-ray hardware available as well. My only frustration is how the costs of hardware have rarely gone down. It is still very expensive to buy a digital X-ray tool in India. So if there's any way India can innovate and develop ultra portable indigenous X-ray hardware technology to match India's ability in AI, then I think we have a terrific opportunity to move the needle. India, for example, developed point of care ultrasound technologies indigenously. I'd love to see India invest more in X-ray hardware to make it really affordable and decentralizable. And then the next thing we can do is take testing as close to home as possible. At a minimum, sample collection should be done as close to people's homes as possible. And I think COVID shows us that it is possible to decentralize sample collection, and it'll be nice to see it happen for TB as well. So can we collect sputum samples in people's homes or close to homes at near neighborhood pharmacies, private provider clinics, so on and so forth, would be extremely helpful. I fully agree with Dr. Nishant's comment. The future really lies in phasing out smear microscopy. We have to have a timeline where we say by 2025 or whatever that timeline is, we will no longer use sputum smears. We will migrate all frontline TB testing to molecular testing. Just like we want to get rid of injectable drugs from TB, we also have to find a way to end smear microscopy. In my opinion, India is still too reliant on smear microscopy. And I can see the plan to phase smear microscopy out and replace by molecular testing, but we need to really show some urgency there. We simply cannot manage with smears anymore. And I think COVID has shown us that if we want to, we can do millions of PCRs and molecular tests. There's no reason why we can't bring that level of ambition to TB. And then better samples in terms of migrating from sputum to oral swabs or other easy to collect samples from patients is another exciting area of TB innovation. Oral swabs are not ready yet to use in routine clinical practice, but a lot of groups are working on trying to optimize it because it's much easier to collect than sputum smears. And then lastly, integrated testing. I know there's a lot of interest in bidirectional testing. I think bidirectional testing makes sense when there's a big COVID surge happening. But right now in India, if the COVID case load is very low, I'm not sure why we would waste money and resources looking for COVID in someone with a classic TB presentation or looking for TB with someone with 1 day of scratchy throat or fever. The syndromes are quite distinct, and I think we need to learn how to target and integrate better. What I would love to see, however, is integration across disease areas with all molecular testing platforms. So whether it's a TrueNat or whether it's GeneXpert or whether it's an RT-PCR, can we do TB, HIV, malaria, dengue, whatever, as an integrated, optimized usage of all of the installed molecular technology? I think it'll be nice for someone in India now, with COVID having happened, what is the installed molecular capacity across India, counting all commercial, non-commercial platforms? And how is it that they can all be integrated to deliver essential diagnostics as per Indian government National Essential Diagnostics List? that integrated testing and optimization, I think Find and others have worked a lot on diagnostic network optimization. I think diagnostic network optimization across all molecular multi-disease platforms for India as a whole will be great, because TB will benefit, other disease areas will also benefit. I think that is the future for all of us. How do we repurpose the fantastic molecular technology? And also India has done a lot of sequencing for COVID-19. And can we now repurpose all of the sequencing capacity to do surveillance around drug-resistant TB is another area where I think we can pivot from what we've been doing on COVID to address TB and other diseases. Thank you.
Excellent, Professor Pai. So, you touched upon TB and COVID. So I would also request you to let us know about the challenge of TB detection alongside COVID-19.
I think, like I said, the challenge for us in the early days was that these were very similar respiratory syndromes, cough and fever. But I have a feeling that now, especially in the Omicron subvariants phase, that classic presentation of COVID is no longer in the dominant pattern. Most people are having, scratchy sore throat and acute fever and body pain and symptoms like that. So, and it's a very short duration presentation, while TB is genuinely a chronic, insidious 2 to 3 weeks of cough and fever. So I have a feeling that these are not that easy to confuse anymore. So I think we need to be careful about spending too much resources when the COVID caseload is low. TB caseload is high and it continues to be high, but COVID keeps going up and down. So maybe when there's a surge, there's a need for bidirectional testing. When there is no surge, we don't need to invest resources and that, because each molecular test costs a lot of money. So if you're going to do COVID and TB, you're paying twice the amount of money. I think better targeting at the correct syndromes in a sequential manner might be a smarter way to do it. I think it depends on the epidemiology of COVID is what I'm saying. We just can't have a policy across the board. If there is no surge, if there's very little COVID, why would we go looking for it in all people with suspected TB and vice versa?
Definitely. So like you just touched upon limited resources and budget. So do you think we should have some target population in mind for TB and COVID bidirectional or integrated testing? Do we need to be more defined, or our aim should be catch all? So what do you have to say about this, Professor Pai?
I think for COVID, we are starting to see that rapid antigen tests are much more easy to access, less expensive, and decentralizable compared to molecular testing. So there will still be a molecular testing requirement for COVID, but I think more and more frontline rapid antigen tests for COVID might be a smart initial use of that technology. Unfortunately, we don't have a rapid antigen test for TB yet. We do have the urine LAM, which is an antigen detection test, but it's still a very niche test for people with HIV and immunocompromised people. Find is working on the Fuji-LAM assay, and we can hear more from Sanjay on whether it will be ready for prime time anytime soon. But if we could have rapid antigen tests for both infections as an early test followed by molecular testing, that might help us manage our resources better.
Okay, thank you, Professor Pai. I have one more question for you. So you talked about digital X-ray, better screening tools. So, to build a robust pipeline, can you please let us know that does one size fit all with regards to TB diagnostics? And according to you, where do we stand with regards to reimagining our TB screening tools?
I think TB screening is an area where we still need better tools. We don't have a lot for triage. The only bankable triage test so far is a digital X-ray with or without an AI software. There is some work done on C-reactive protein, an inflammatory marker, but I'm not really sure that's ready for prime time use. So there isn't anything biomarker test that is easy, decentralizable to the community level that we can use for screening. To that extent, Dr. Nishant's comment about wanting a genuine point of care test for self-testing, we are not there yet. And that's where I think future R&D investments would be immensely helpful. Something like a COVID rapid antigen test for TB would be incredibly valuable. Unfortunately, we are not there yet. So for now, greater use of digital X-rays combined with the AI or radiology reading and integration across disease area for AI screening. So the AI algorithm can look for different causes of lung abnormalities and help us differentiate between TB and COVID or other infections. That would be an advance. For now, I think the technology is matured enough for us to use portable X-rays and digital AI right away. There's no barrier to it. What is unclear to me is how do you target in a big country like India? There's no point in going door to door and screening millions of people because it's going to be very resource intensive. Can we use some kind of predictive analytics to focus on hotspots where screening would be much more beneficial, or subpopulations where our likelihood of finding TB is very high, or find ways to engage with the private sector, which is already using a lot of X-rays, and find them and link them to the RNTCP effort. So I'll let Kayla speak to that.
Sure. So thank you so much, Professor Pai, for your insights. And moving on, I would request Dr. Sanjay Sareen to let us know more about the emerging multi-disease platform technologies for diagnosis of TB. And we have a short presentation from Dr. Sareen in this regard.
Thanks, Dr. Shikha. I'll just wait for the slides to come up. Okay, great. Can we move to the next slide, please? You can click through the slide. So I'm not going to spend too much time on this slide. I think Dr. Nishant and Dr. Madhukar Pai have both spoken about the huge reverses that the world has seen in terms of the progress towards TB on account of the COVID pandemic. I mean, almost 12 years of the fight against the global fight against TB, they have been wiped out by just a couple of years on account of COVID-19 pandemic. Can you click through? Yeah, I mean, as Dr. Pai said, testing obviously remains the weakest link in the cascade, and this is something which we need to urgently address to support the global recovery of TB case notifications. Some of the gaps and some of the root causes are obviously the existing tools. All of them are not fit for purpose. I think we still continue to use sputum microscopy in a lot of the LMICs. More than 70% of the patients that are initiating care at the community and the PHC, where there is no suitable capacity or an appropriate diagnostic tool to diagnose tuberculosis. The symptom screens are not so accurate, and they miss a large percentage of the TB cases. Sputum is not necessarily the best sample as far as TB diagnosis is concerned, and it is great to see that there is a lot of work that is ongoing in terms of looking at alternative samples for TB testing. Please click. The pandemic over the last 2 years, there have been some unprecedented investments around diagnostic development, and through the rapid antigen tests, for example, the diagnostics is now closer to the patients. There have been huge investments around developing a diverse molecular diagnostics portfolio, and then there is likely we are moving towards an era where there is no longer one size fits all kind of platforms. Dr. Pai, he mentioned about the significant investments around digital infrastructure as well as connectivity to ensure that the programs and the policymakers are able to review the testing data and the disease incidence in real times. And then, I'll not speak about this in this presentation, but there is, a recent WHO recommendation around some of the new TB infection tests which open up more frontiers. Next slide. So please click through. So, Urine lab tests are in fact nothing new, and they have been available since 2015 when the WHO published their first guidelines recommending their use for diagnosis of TB and HIV patients. However, we all know that the adoption of the urine lab test has been suboptimal, primarily because of the need for CD4 testing, as it is most suitable in patients who are, particularly severely ill with HIV. However, all that is hopefully set to change now, as there are currently at least 8 manufacturers that are working to come up with a test which will be essentially suitable for all patients irrespective of their HIV status. There are essentially 3 approaches that are being pursued as far as the development of a LAM test is concerned. So one is around improving the sensitivity of the reagents that are being used for capturing the LAM. Then there's another bunch of developers which is working on specifically for sample preparation, because the idea is to be able to concentrate the urine sample so that you are able to pick up LAM in sufficient quantities. And then there are quite a few developers who are also working on innovative assay designs, which are more easily applicable and potentially be used as primary healthcare level settings. On your the slide also shows on the left bottom corner an image of the Fiji LAM test, which FINE has been extensively trialing across the countries. We do expect the first design log products to be available. I mean, there are extensive trials already going on. A lot of feedback has gone back to the developers, and we are expecting more to come through in early 2023. Next slide. Next, we have a bunch of potentially disruptive technologies, which, for example, are currently using swab-based samples instead of sputum for TB detection. On the screen, you see a technology where there have been significant investments, for example, from the Gates Foundation and others. This is known as the Lumira DX. The technology has been extensively used in Africa for COVID-19, where there are currently more than 5,000 installations. It is a pretty simple technology to use, and then because of the unique technology or the mix that they have, they're actually able to achieve a result, within 15 minutes. And then the fact that they're using swab instead of sputum as a sample, further makes it easy. There is also, the device promises seamless and secure connectivity to the health IT systems, making it easier for the policy makers to be able to capture data in as close to real time as possible. They have been working on a TB assay, which is expected somewhere around late 2022 and 2023. Again, FINE, along with a few partners, including BMGF, is increasingly getting engaged in trialing these technologies extensively. Next slide. This is a very quick snapshot of the currently available molecular diagnostic technologies. On the left, you see the cartridge-based technologies, which everyone is very familiar with. You have the Cepheids and the TrueNAS of the world, who now have chips for both the first line as well as second line DST. In the middle, you have a relatively new bunch of intermediate range multiplex PCR platforms. As you can see, these are both Korean platforms. ST Biosensor, a lot of you would have heard, they were also the ones to come up with the antigen RDT for COVID-19. They have extensive menus, including for TB, and we FINE is currently involved in, or will be shortly starting the trialing of these technologies towards Q2 2022. On the right-hand side, you again see a whole range of technologies or the high throughput platforms that have already been approved by WHO from companies like Abbott, Hain, Becton Dickinson, and Roche. A lot of these technologies, especially from Roche and Abbott, they have been placed in countries including India as a part of the investments into COVID diagnostics infrastructure. And there is an opportunity now for the program to be able to leverage these technologies for rapidly catching up on the missing TB case notifications. Please click. And as Dr. Madhu Pai also mentioned, there is an exciting new pipeline of targeted next-gen sequencing platforms. FINE is currently working in solutions which can potentially enable comprehensive DST straight from the sputum, which further minimizes the time to diagnosis, as you don't necessarily have to culture the sample, which takes its own time. There is an end-to-end solutions review, which is planned by WHO in 2022, and hopefully we'll have an IVD-approved assay for drug-resistant TB, sometime in 2023 if all goes well. We also conducted a landscape review, and what is exciting to see is that there are nearly 155 true or near point of care platforms, and this is as of November 2021. We identified at least very promising 11 true point of care and then 39 near point of care. So when I say true point of care, these are technologies like the TrueNAT and the Cepheid. And when you say point of care, it is technologies more in the range of Lumira DX or something like urine lab tests. So an exciting time ahead as far as the TB diagnostics pipeline is concerned. Thank you, Shikha.
Thank you so much, Dr. Sareen, for the wonderful insights and taking us through the diagnostic pipeline. I was very interested to know the disruptive technologies as well. So thank you for enlightening us. So moving on, now our next expert is Professor Paul Lalwani, and he is going to tell us more about strengthening capacities of health workforce for adoption of TB novel diagnostics. And Professor Paul has a short presentation for us. So over to you. Thank you.
Thank you very much, Dr. Shikha. If I could just ask Mohit to share the screen, and while we're doing that, let me kick off first of all by thanking everybody, and thank you for the invite, and thank you IHF and FIND for organizing this along with the Ministry of Health and the CTD. If we are to fully realize the impact of innovation and technology, then we must have a fully empowered and knowledgeable workforce, health workforce. And if our intent is to decentralize and take our innovations and technology, the diagnostics, to the point of care, to the front line, then we need to do the same for knowledge and learning. They need to reach the frontline health workers. They need to reach the caregivers. They need to reach the patients themselves. And this is the area of focus for Empower School of Health. Mohit, are you able to?
I can't share disabled, so I request the host to please give me access to.
Okay, you are co-host now, it says. You might be able to share.
Yeah, I can.
Okay. So we can go on to the second slide, just very briefly about Empower School of Health. Our focus is in capacity building, and we focus specifically in areas of global health, and we bring digital learning. That's our DNA, digital learning and large-scale capacity building in global health. We work significantly with TB and TB partners, but we also work across nutrition, supply chain, access to medicines, COVID, and other areas as well. Next slide, please. So the topic that I'll be speaking on is challenges in the TB sector, and specifically around knowledge and learning and strengthening the health workforce. And the problem statement, the way we look at it, is that there are 3 Ps that we're always running behind. And that's people, products, and policies. And when it comes to capacity building, we need to keep in mind that people keep transitioning. There's over 3 million health workers across India, if you look at it from the formal health workers all the way to ASHA and Anganwadi workers as well. When we look at products, they keep changing. Innovation is accelerating, and you saw all the examples that Dr. Sareen just showed. And there'll be new and more innovative products coming. But it's just not new technology. Sometimes there is marginal change. Maybe there's a software update or a cartridge update. All of these slight changes or change in diluent, we need to go back to the drawing board, and we need to train and upgrade the health workers. So as we keep innovating, we have to keep informing and strengthening the workforce. And policies and processes keep evolving. And that is natural as well. So as these keep evolving, we need to make sure that we set sort of the train tracks of knowledge and information into the system. And instead of focusing on behind the curve and running behind the curve in terms of training, the idea is to be proactive and make sure that knowledge is available at scale. Next. So Empower's response is to provide large-scale digital learning which is scalable, customizable, and cost-effective. And the idea is to disseminate continuous learning and knowledge transfer to elicit behavior change. It can't be once a year or twice a year. It has to be continuous, and there has to be systems for this to strengthen both institutions, where the focus should be on ensuring there's institutional memory, institutional knowledge, and capturing that knowledge and information of policies, manuals, guidelines, and making it available on demand. And on the other side, focusing on individuals and making sure that whether you are a PhD and you have you're a subject matter expert, or you're a frontline health worker, how do we get the right content, the right information to you in that context? Next. Here are some examples of the work that we've been doing along with, this is just in India. These are India examples of working with the CTD, funding from USAID partners such as Union, Fine, Johnson & Johnson, among others as well. And just to change things up a little bit, we're going to show you a short 60-second video of samples of the kind of innovation that we bring for learning. So Mohit, if you want to, yeah, thank you. Okay, I don't hear the sound, but it's okay. Normally there's some exciting sound that goes with this as well. But let me just continue speaking. So we're exploring areas of augmented reality, bringing, you don't need any headset or anything else, where a combination of just a regular software can bring the learning in a new and creative format to the learners with just a simple mobile device. Different innovative ways of showing the follow-up schedule for medication and medicines and how it should look, okay? Simplifying it. And again, this is for training, learning purposes. Different visuals, different flipbook designs. Some of these are very low cost and rapidly and easily done. You can add sound to this and everything else, okay? Mohit, actually, if you can just skip forward to nearly to the end, the last 30 seconds. There's some different samples, yeah? Keep going, keep going, keep going. Further, 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 yeah? All right, needs to catch up, keep going. Yep, that's fine, so let's stop there. So these are courses that we worked on in partnership with WHO and the CTD for the Swasti Gurukul platform. Find and Union were also partners in this with USAID supporting us. Again, creative, new, innovative ways of learning, whether through your smartphone or your computer. But in the last mile, in the front line, it's mostly mobile phones that are being used. All right, and then again, other creative ways of trying to see and understand how we can convert a 2D environment into a 3D environment for learning. All right, that's fine. Thank you very much, Mohit. We can go back to the slide deck. So, yeah. So the approach that we take for learning and dissemination is applying a human-centered approach, starting with the discover process and really focused on from a needs assessment point of view. What does the target audience need? Are we talking about a policymaker sitting at CTD and the Ministry of Health? Are we looking at a state TB officer, or are we looking at a caregiver at the last mile? Okay. Very different design, very different approaches, very different bandwidths and hardware that they would have access to. Then coming up with the design, learning, and engagement strategy. Here we have learning specialists, curriculum design specialists that come from the education sector, working in the public health sector with us. Then you've got all the incredible creativity that goes in, which includes from graphic designers, audio designers, software designers, all working together to develop the necessary content. And then this is where the rubber hits the road, so to speak, is when we deliver the learning and measure impact. This is really to see what we've created. Does it work? Does it not work? Did we create the necessary outcomes that we were hoping for, and how did we get there? And part of the deliver, which is not mentioned here, which we'll add next time, and that we do a lot of, is generate demand, because there's so much information out there. We absolutely need to, as much as everything else, we need to be a marketing agency, a brand generation agency, along with our partners, to make sure that the learners come and learn, whether it's with CPD points or certificates, however it is that we must promote that. And finally, knowing that this is a continuous process, as soon as one change happens, there'll be another change coming a month later or 2 months later with a new technology and with people transitioning. How do we scale, sustain, and build partnerships, the evolution subsequently? Next. So, well, there's all of this work, and this is a critical part of it all. And there is so much work that is being done in this area, impact measurement. And this is usually conducted at the individual level. Did the individual enjoy the learning experience? Did their knowledge increase? Were they able to apply their learning? Was there a behavioral change in the process? So was there organizational impact as well? And finally, was there impact in terms of public health impact? Not easy to measure. The ones on the left-hand side of the scale are somewhat easier. As we move further right, it requires a rather large sample set and a longer duration to be able to really measure that. Next. Yep, thank you very much. So in ending, just to say that, I mean, everything that we've heard so far, we know there's going to be more innovation. And with that innovation, we must absolutely think about empowering and transferring knowledge and information to all the health workforce. Over, and Shikha, back to you.
Thank you, Professor Paul, for bringing out the work Empower is doing. And also what we understood is that capacity building and training of health force requires the right number of people to be trained with the right skills at the right place at the right time, and also keeping up with advances in technology, changes in policy, e-learning methodologies, and of course, upskilling to develop human resources for TB diagnostics. So thank you very much. And now I invite Dr. Kela. So Dr. Kela, we would like to know about the public-private partnership and role of private sector in financing TB care in India. So I have a few questions for you. Dr. Kela, could you kindly elaborate on BMGF's role in supporting continuum of TB care in India and the pilots which the Gates Foundation has been introducing the program to introduce, especially with regards to taking up new diagnostics? And Professor Pai specifically mentioned your role in bringing out new diagnostics that can be used for screening. And probably if you could also know how these pilots can be scaled up and sustainability is ensured. Over to you, Dr. Kela.
Thank you so much for the invitation and the opportunity to speak. I know we're slightly running out of time, but so a couple different things on those questions. One is the Gates Foundation in India has really been supporting the private sector engagement. So knowing that so many TB patients will go to the private sector as their first point of contact, or want to continue in the private sector for over many years, the last 8-9 years, we've been supporting different models within the private sector to ensure that patients are diagnosed, that they're treated completely, and they're notified to the TB program. And that's been in collaboration with the Central TB Program and WHO and many partners to find the right models that work. And this is now being scaled up by the program. These different models where an intermediary agency will help in the private sector. The private sector practitioners help to identify patients, help to make sure treatment is completed, and make sure those patients are notified. And there were a lot of different elements to that model, including free treatment, free diagnostics, so that those patients could receive those services And those providers could have those services, and that would ensure patients could get those services, they could be notified appropriately, and also they would stay in the program. So those were really important models that were done a number of years ago, and were embraced by everyone in the program, together with various partners to scale that up across the country. And that's a really important model to ensure that the private sector TB patients are found and identified. Now, within that are the diagnostics. And whatever diagnostic is being used, is important that those private sector patients also get that diagnostic. And so as new diagnostics will come in, the kinds of diagnostics that Dr. Mandi talked about, and Dr. Sareen talked about, and Dr. Nishant, was hoping for, as those come in, we certainly want to be part of supporting those diagnostics and also getting them into both the private and the public sector. There are many barriers, including transport of specimens and all the various issues that are the barriers to getting diagnosis, the costs. And we had some interesting private sector innovations that weren't about a new diagnostic test, but were innovations. So, for example, working with our partner CHI, there was a private sector coalition called ICOT, the Initiative for Promoting Affordable and Quality TB Care, where the diagnostic manufacturers, together with the CTD and the whole national program, had kind of a win-win situation where they limited the cost of the test so that the cost for patients was lowered. It was more available. They followed the TB standards of care in the country, and they promised to notify TB patients. And so many more diagnostic tests were used, but the costs were lowered through a kind of a coalition of these manufacturers and kit producers. That kind of thing can really help. So that was sort of an innovation, not a new diagnosis.
Dr. Kayla, I'm going to interrupt. Your voice is not very clear.
Oh, sorry.
Yeah, we are losing you at times. Yes.
Oh, let me go off video. Okay. Is that better?
Yes, seems like it's much better. Thank you.
Okay. So I was just talking about the ICOT to create that ceiling price for TB diagnostics. So that was an important innovation. And then we've seen, as Dr. Mandi mentioned, so much innovation via the private sector for COVID testing, which is, at-home sample collection, bringing the samples across cities, across the country, very, very quickly. So leveraging all the COVID innovations from the private sector and the public sector are really important as we move forward in TB. We've seen so much private sector engagement in that, and being able to leverage that is really important going forward for TB diagnostics. In addition, there's been sort of the coming of the Integrated Public Health Lab, which is part of the the Health Infrastructure Mission initiative. And those integrated public health labs are at the district level, and they serve the blocks, and the blocks serve the health and wellness centers. And TB can fold into that entire kind of cascade as well, which will again bring TB diagnostics closer to the patient, as was mentioned by our speaker, and how important that is. So we've at the foundation supported kind of that private sector look at all of the levels, whether it's diagnosis, treatment, completion of treatment, and notification, the NICHE information system. All of that has been part of what the foundation has been supporting the Central TB program with. Thanks.
Thank you, Dr. Kayla. So I have another question for you. What do you think are the health system related barriers in TB testing? And how, in your opinion, the private sector can pitch in to reduce these barriers?
Right, thank you. Yeah, so some of that I addressed. I think that moving samples is quite difficult. The costs of the test are still too high, even with this kind of agreement. And so bringing those costs down, bringing sample transportation closer again to the patient, as was already mentioned, either at home collection or at the health and wellness center collection. I think the private sector has an important role to play in innovative models, innovative structures to be able to reach that patient at the bedside, or to get the sample from the bedside, and to move into private labs. Private labs can do the drug-resistant testing, can do regular TB testing. So I think the private sector laboratory infrastructure has a very important role to play in addition to the public sector laboratory structure. And I think some of the kind of innovative transportation, innovative tools can come from the private sector, or certainly be supported through the private sector, especially for the private sector TB patients, which is a large proportion. Over.
Definitely. Well said. Now, when you're talking about sample collection, which private sector can pitch in, I have a question that aligns to it. So in your opinion, how efficiently we can develop hub and spoke models to increase referrals for TB testing under public-private partnerships? And you also talked about integrated public health laboratories. So, that is hinging on the hub and spoke model. So
yes.
If we use these learnings for getting more specimen referrals from private sector, in which public-private partnerships can have a role. Can you please comment on that?
Yeah, so the kind of intermediary model that I mentioned before that we've used for the private sector for TB is sort of a hub and spoke model. There are hubs and at high load centers, and then they take samples from low load centers and test them at those high load centers, or together move them to a laboratory that can test them. So that entire private sector model was have a hub and spoke component to it. As we move into the integrated public health laboratory, then similarly, the district becomes the hub for the block, which is the spoke, and the block becomes the hub for the health and wellness centers, which become the spoke. And so that kind of cascade or tiered laboratory system is going to be very important going forward, not just for TB. I do think what Dr. Mavi said and Dr. Sareen about multi-pathogen testing is going to be essential in these health and wellness centers, or in the district hospitals, or in the block level community health centers. You're going to see people coming in just with fever. You need to be able to test for multiple pathogens at once. And so I think that push, leveraging the kind of COVID success of molecular testing and the widespread rapid testing will be really important to leverage multi-pathogen testing at these hubs for the spokes around them.
Okay, so that's wonderful, Dr. Kela, and we are very glad to know that the foundation would be supporting a lot of innovations and a lot of pilots. So I thank the esteemed panel for the insights today, and just for a quick summary. So today we have learned that sustainability and scale up of innovative models and pilots for TB diagnostics is essential for the goal of TB elimination in India by 2025. As Professor Pai highlighted, COVID pandemic is a very good teacher. It has taught us to develop resilient health systems. We have learned to repurpose our diagnostic tools. We are doing bidirectional screening of TB and COVID. And what Professor Pai brought out today, that we have to give more stress on digitization of TB data with emphasis on active case finding. And as Dr. Nishant had said, NTP has scaled up journey from passive case finding to intensified and active case finding to population-based screening. So I guess we are in the right direction. And Professor Pai stressed on having digital X-ray hardware solutions. Kela and Professor Pai, they stressed upon taking sample collection closer to people's home. So in fact, that is the innovation the country needs. So another thing that came out in discussion today, that we have to phase out smear microscopy, and with 8,000 plus molecular diagnostic platforms, including at the block level. So we are all poised to migrate to molecular testing. Dr. Sareen highlighted there's a robust TB pipeline with emerging multiplex disease platforms that can be leveraged even for TB diagnostics. Dr. Kela brought about that private sector is playing a very crucial role in continuum of care for TB including for TB diagnostics, with the pilots on free diagnostics and free drugs have been successful. Private sector innovations and in TB have created a win-win situation to bring down costs of TB diagnostics in the private sector. We spoke about integrated public health labs. We spoke about hub and spoke models so that referrals can be increased from private sector. We talked about taking diagnostic closer to people and enhancing TB notification. And Professor Paul, he brought us on page that we have to keep up pace with advances in technology, policies changes. So basically, we are on the right path with support from partners like Empower to develop human resources for health. And if I may also add, human resources for universal health. So I guess, Jaita, do we have time to take in questions from our esteemed audience? Or do you think in the paucity of time, we move ahead?
A very important point, Dr. Shikha. So what we're doing is that we've kept track of all the questions and also noted the persons who are sending in the questions. So we stay committed to take all the questions from the audience to relevant panelists after the session. We'll seek their responses and get back. We'll find a way to get back. So we will try our best to, at least keep to the time that we have planned for this webinar. And I hope the audience will also understand. So we definitely make a commitment that we will come back to the audience with responses on the questions. But please keep your questions coming, audience. And I mean, very, very critical ones. Thank you.
Yeah, thank you, Jaita, for the clarification. And we want to tell our audience all the questions are important and keep posting them. And we will make all efforts to get back to you over email. So Jaita, over to you again.
Yeah, thank you. And I did note that Dr. Pai was already trying his best to respond to a whole lot of questions on the chat box itself, but there may be many more questions which are unanswered. We will definitely take them. So thank you, Dr. Shikha, for moderating the session. And thanks to all the 4 panelists for an enriching discussion. This, as we all know, this discussion is not just for academic purposes, but to ensure how we can take some of the insights shared here, the knowledge and learning shared here, and we will see how, all of us as a collective take some of these insights into future course of action at our level. So now, we did hear, as Dr. Shikha, you concluded, we did hear the emphasis from all the panelists on multiple aspects, right from screening and testing onwards, the role of private and public sector, need for more and more innovations. We heard about the pipeline and, of course, the need for enhancing knowledge and learning for the workforce by using modern technologies. We did hear about also digital platforms and artificial intelligence, along with the growing pipeline of testing, diagnostic and testing solutions. Okay, we will now move to the last session of the webinar. So we are going to be using a case study format. And so in the first panel, we heard about the need, the possible way forward. And in this panel, we will actually hear about 2 innovative pilots, which were tried out, one in Mumbai and the other in Uttar Pradesh, by using TrueNat. So we will hear from the implementers, from the government who are here, and to share their experience and learnings from these innovative pilots. And as we believe that these learnings will definitely help as we go forward in terms of scaling and replicating. So yes, Dr. Shikha, over to you again to moderate the session on the next panel, which is on learning from innovative pilots and using TrueNat as a case study.
Thank you so much, Jaita. And as Jaita mentioned, moving on, we have gathered today learnings from innovative pilots that have used TrueNat as a case study to bring in an ecosystem for faster diagnosis and early treatment initiation of tuberculosis. Now, again, if the audience have any questions, I please request them to keep on posting them in the QA box. And now to present our first case study on bidirectional interventions for COVID and TB in BMC health facilities in Mumbai, we have Dr. Mangla Gomare. Madam is Executive Health Officer at Brihan Mumbai Municipal Corporation, and she will be supported by a team from FIND comprising of Dr. Sarajit Chadda, the Regional Technical Director, Dr. Shubda, Medical Officer, and Ms. Rajshri, Senior Manager, Country Programs at FIND. So over to you, Dr. Mangla, and if you could have her presentation up, please.
Am I audible?
You are, yes, yes, you
madam.
are.
Okay. Meanwhile, yeah, presentation is getting uploaded. Good evening to all of you, to all the speakers, officials from the Central TB Division, then IHF and FIND, and also all the speakers, previous speakers. Good evening to all. I am really thankful to all the organizers for giving me this opportunity to present this bidirectional study report from Mumbai. First slide. Acha, who is Rajeshri? You are showing the slides?
No, I think Tushar, can you please switch to the next slide? Yes.
Yeah. As you all of know that Mumbai was the worst hit as far as COVID pandemic was concerned. We have faced 3 waves in city of Mumbai. First wave was, I mean, that time there were maximum number of deaths happened, and we were not knowing how to manage the cases of this COVID cases during that period. The second wave, we had 2,800 cases in a day. And then in the third wave, we have seen up to 20,000 COVID cases in a day. And as a result of all of this, and up till now, we have seen more than 10 lakhs of cases reported in city of Mumbai, with around 20,000 unfortunate deaths during COVID. And because of this COVID pandemic, naturally, as everybody has said, that there is a huge less number of notification happened in TB, which was gaining a momentum for notification as well as management of cases during 2016 to 19. And even in Mumbai, we had maximum notification happened in 2019. That was 60,000 cases, 60,000 cases reported in 2019. But in 20 and 21, again, less number of cases reported. And that, I think it is around 30% reduction we have seen in notification of TB cases. So how to improve the notification, how to improve the surveillance, how to improve the survey was the main objective for all of us. And then we had a meeting with this IHF and FIND people. We were planning to have more TB testing and notification during that period. So I think they have supported with lot of logistics, material, TrueNet machines, and we started this survey in some of the medical colleges. As you know all this about the Indian scenario, but I just wanted to highlight about the Mumbai that yes, we also suffered a lot in city of Mumbai as far as TB notification was concerned. Next. Yeah, next slide, please. And then in order to prevent this disruption to TB detection, we in BMC explored many opportunistic, intensified and strategic screening of TB and COVID-19 to create combined screening pathways. Through these measures, TB notification was brought back to almost pre-COVID levels in Mumbai. Now in 2021, we had almost 59,000 cases were reported or notified. Yeah. Next. In 2021, as you all know, that along with the partnership from FIND and IHF, we initiated bi-directional screening of all walk-in patients, suspected patients of COVID, as well as in TB OPD, with 4 major hospitals in city of Mumbai. One was Sion Hospital, Rajawadi. Then we have one peripheral hospital, HBT Hospital, Cooper Hospital, and Nair Hospital. Out of all these 5, Sion could not take part into this because of some reasons. But these 4 were the major centers selected for this. And then this was part of larger initiative under the partnership to provide on-site TrueNAT testing for rapid, the negative, symptomatically positive patients, but found antigen negative COVID symptomatic patients. Then walk-ins at COVID-19 OPDs were screened using all those general questionnaire for TB presumptive cases. Then COVID-19 positive cases were isolated, and then for maybe 14 days or as per the prevailing guidelines of Government of India. And then telephonically TB screening was conducted after that, after their isolation period was over. Then walk-in patients at TB OPDs and health post also were offered with COVID testing, either antigen COVID or RT-PCR. All presumptives were offered TrueNAT seminar testing on the site itself. Positive COVID-19 patients were linked to BMC's either CCC2 facility, DCHC or DCH facility. And the same way, positive TB patients were linked to the TB program through concerned DTOs. Yeah, next. These were the sites selected: Nair Hospital, Cooper Hospital, Trauma Hospital. These were medical college hospitals, and then Rajawadi, one of the peripheral hospitals. Sion again was a medical college hospital, but did not participate in COVID TB, that bi-directional screening. What we got under this project was a TrueNAT machine with printer and other accessories, a lab technician to assist in testing, and plus patient follow-up agent to administer questionnaires, and COVID-19 and TB TrueNAT cartridges, plus sample transport media, swabs, reagents, etc. Apart from all this TB COVID simultaneous screening, the project also increased rapid access to on-site confirmatory testing for antigen rapid to all the COVID suspects, as well as emergency cases and pre-surgery cases also. Up till now, we have conducted more than 18,000 plus TrueNAT SARS-CoV-2 RT-PCR tests for all those antigen negative symptomatic patients or emergency or pre-surgery cases from January to December. And for the COVID-19 testing, the average TAT was around 3.5 hours. Next, please. These were the 2 scenarios where we worked, one in COVID OPD and other in the TB OPD. This is how we did the screening of COVID OPD patients for TB. All presumptive COVID-19 patients were subjected for rapid antigen test. And if that is positive, then it's okay. Otherwise, all those symptomatic antigen negative patients were subjected for either TrueNAT or this RT-PCR. Then accordingly, the TB sample collection was done. And then after that, if it is positive, then we're referred to the system through concerned DTOs. And if it is COVID positive, they were isolated, they were treated there. And after that, again, the protocols were followed for them. And TB testing was either done on CBNATs or TrueNATs. And as per the result, they were subjected for further management of the cases. Next. screening of TB OPD walk-in patients for COVID-19 testing. During the period which we conducted these bidirectional studies, like it was in September to December. So that time, most of the that time we were facing the wave 2, I think, yeah, and maximum number of COVID test patients also were there. So we had a good response here. All those patients who were there in the TB OPD, everybody was subjected for COVID-19 testing, and as for the result, they were subjected for the management. Next. Next slide, please. Actually, this is one of the very important slides which we discussed a lot yesterday also with all the IHF fine people as well as my team, Dr. Varsha Puri, Dr. Usha Shelar, and so many others also. What we have seen during this project was like we have screened 14,500 COVID-19 suspects. They were screened for TB. And out of that, presumptive TB patients were identified with verbal autopsy and all that, were 475. That comes to around 3.3%. Then out of that, around 60% patients, they were tested for, I mean, we could get them tested for tuberculosis. And out of 288, 32 actually they were diagnosed as TB positives. This is like TB ill. What we got was 219 per 1 lakh patients screened. This actually I wanted to correlate with the actual TB scenario in city of Mumbai and how we are doing the screening in all the health facility OPDs, and also sometimes strategic surveys, sometimes population-based surveys also. But I will just compare this study with our exactly scenario in city of Mumbai as far as this OPD screening is concerned, general OPD screening is concerned. In Mumbai, we had around 1,75,964 to be very precise, presumptive TB cases, which were reported through Nikshay portal. And then all those, I'm really proud to say that 100% were subjected for TB testing. And then out of that 1,75,000, some 900 cases, we got 59,120 notified in last year, that is 2021. And that comes to 33% of all cases were diagnosed of the screened cases. This is actually, this slide actually is there for all the experts again to take the review and analyze further. But as far as this TB OPD report is concerned, then we had 886 presumptive TB patients who were screened for COVID-19. And as per the prevailing situation of COVID during that period, definitely almost all were subjected for COVID testing, at least for rapid antigen testing. And here it is seen that around more than 75% were screened or tested, and out of that 3% they turned out to be COVID-19 positive. Actually, at that time in Mumbai, the positivity rate was, I think it was more than 10%. So here, I don't know how we got so less positivity here, but yes, these are the reports. And as far as COVID ill is concerned, we have then 1919 per 1 lakh patients screened. Yeah, next slide. Yeah, you can go ahead. I have explained already this slide. So some key insights. The field experience demonstrates that simultaneous TB and COVID-19 screening can be implemented successfully using all those tools, verbal screening and on-site molecular devices, but maybe with more meticulous planning and regular reviews and at the maybe peripheral level. We conducted all these studies at very tertiary centers like medical colleges, academic centers. But I feel if we go with all these infrastructure and all these modalities, we can take to periphery, then it will be more beneficial, what I feel. Then this project also demonstrated that operational workflows for TB and COVID-19 could be combined. And very important thing is that key factor, whatever success we have seen in this project is because that COVID-19 and TB responses were managed under the same team, same leadership from BMC's health department. So that time Dr. Tipri was managing this, and she was also in charge and supervisory level at for COVID testing as well as this TB testing. So maybe we have seen more success because of a single authority managing both the kind of a testing and screening. The implementation of the project was conducted in close collaboration with the hospital sites. But again, I would like to say that if we can take it to periphery, it will be more helpful and beneficial. Of course, this project was governed by a steering committee and closely monitored with regular follow-up visits, calls, and timely course corrections. I heard today that weekly meetings were happening between all those NTP staff and as well as IHF and FIND staff. Next slide, please. Next. Yeah. Some future action points from our intervention is that integration of screening touch point for the best patient experience. Most beneficial if screening at a single touch point conducted by a single personnel. For example, can we use a single questionnaire in future for screening? I don't know. As whatever we were discussing, and we discussed amongst all my staff members also, that the previous speaker, Dr. Madhukar, has rightly said and analyzed about this bidirectional screening. Maybe during that period, most of the COVID prevalence was very high. So that little bit helped us, COVID and TB bidirectional screening. But now in city of Mumbai, we do not have COVID cases. Prevalence is very, very less. So whether such kind of bidirectional studies with so much of a human resources, so much of a manpower, so much of a infrastructure and equipments and all those logistics, I don't know what kind of result will come out of this bidirectional. Then second is use of single sample type and test cartridge if possible. So that way TrueNAT machines are very useful. Now we are not using those machines only for COVID testing, but also for TB. And we are really subjected all those TrueNAT machines for TB screening. But at the same time, if we are started using this at the peripheral level, then TB screening as well as COVID testing also can be done at the same time. So that way, this is very useful. Then strong and sustained coordination and supervision between vertical programs. This is again very, very, very important. But as far as Mumbai city is, as a metro city, whenever there is any program comes in, it has a huge vastness. So most of the time it is seen that different people, they handle different programs, and coordination becomes again sometimes a challenge. But fortunately during that period only one person was handling, so that was again it goes in our favor and for more success to this project. Then readily available and dedicated TB sample collection area to prevent patient fallout. I think this was very interesting point and very important also. I have attended some of your steering committee meetings and I have seen people discussing about this. And really we tried to find out the solution. And I think in some of the hospitals, such kind of dedicated collection area also was made available after the discussions. Then view to maximizing capacity reach. Machines HR can be maximized and geo coverage increase. Yes, of course, if it is there, then definitely yield will be more. Yeah, next. All the machines now have been operationalized. As I told you, all 5 machines, they are being utilized for TB testing, and they are very well maintained under the health department in BMC. Learnings from the pilot are useful in paving the way for integrated testing workflows in Mumbai and across country that include other respiratory illnesses as well. As we are seeing, if we compare the yield through these bidirectional studies and through general studies, we can definitely increase the other respiratory illnesses into that, like ILS, then SARI, and other chronic respiratory illnesses. There also we may get more yield if we do some bidirectional studies. Then the continued use of the platform under the TB program demonstrates strategies for the repurposing of the large diagnostic medical infrastructure added to the country during COVID-19. Thank you.
Thank you so much, Dr. Mangla Gumare, for an excellent presentation. And at the same time, we would also like to acknowledge the support provided by Dr. Tipre for the success of the pilot. Madam, we specifically congratulate you for the massive success achieved in Mumbai under your leadership and undertaking this Herculean task to screen TB in COVID patients.
Yeah, thank you on behalf of everybody. Yeah, from Team BMC.
Thank you so much. Yeah, the entire BMC team under your leadership, madam.
Yes,
The pilot, as you showed, it has highlighted success in operational workflow and building capacity of the existing health staff, because under the pilot, the existing lab technicians were used to conduct tests for TB and COVID. The pilot also showed the way for integration of services at screening touchpoints, which was clearly highlighted by you. And with the success of these pilots, we can go in for use of single type test, same cartridge, multiplex on a diagnostic tool like TrueNat, and coordination and integration between vertical programs was successfully highlighted. So a lot of good has been achieved out of this program. So, madam, I would just like to comment, like Professor Pai also highlighted, and you also shown concern that a lot of resources got built because of COVID, but COVID is coming in surges. We see waves, and then it has low incidence. But what is good to know that these pilots have paved the way that vertical programs can be integrated, machines and manpower can be repurposed. We can build human resource capacity. We could have single sample collection points. Tools can be repurposed. So, a lot of, I would say, capacity has been built in. So BMC and the country as such has been geared up. So basically to take up further challenges, and hope not, we don't see such pandemics in the future. But what we understand is we are perfectly on the way to tackle and use our resources and capacity have been built. And already, madam, you touched upon sustainability, that already these machines with COVID cases low are used for TB case detection. So, madam, in your opinion, could you comment some more learnings on how you would want to maintain the sustainability? So the lab technicians would be available, they are dedicated. So because Mumbai has a very high caseload for detection of TB. So just want to hear from you, madam, how efficiently and how sustainable the learnings from the pilot can be used.
So you want me to tell right now, or maybe we can have some brainstorming and we can give you after that?
Sure, ma'am. Not a problem.
Yeah. But right now, as you said, already we got a momentum. We have already all this because of experience of this project. We have started working in TB more now, and yes, TB diagnosis now, as I told you, in 2021, we have almost reached to the pre-COVID situation. And these TrueNat machines are really helpful in case as a point of care test. And definitely we have already shifted all these machines from medical colleges premises to some of the peripheral hospitals or some of the UPHCs at the periphery, and that is optimally being utilized, and definitely that will help us in getting more screening of TB cases.
Thank you, madam. So really heartening to know that sustainability has been built in, and we thank you for your leadership for all the progress that BMC is undertaking. Thank you so much for your time, madam, and your valuable presentation today. So
Thank
now,
you.
thank you, ma'am. And with that, I would like to move over to our next case study, which is TrueNAT deployment in 5 sites across Bahrain and Sambal from 2019 December to March 2021. And we are going to talk about the impact and feasibility of TrueNAT deployment at CHCs in 2 districts in Uttar Pradesh. For that, today we have our esteemed guest today, Dr. Santosh Gupta, who is State TB Officer of Uttar Pradesh, and he will be supported by Dr. Chandrasekhar Nair, Director and CTO at Malbio Diagnostics Private Limited. So can we request presentation for Dr. Santosh, please?
Good evening, everybody. As you know that UP holds the maximum disease burden of tuberculosis in the country. As I stated, the UP has the dubious distinction of contributing 20% of the total disease load of the country. Every 5th Indian TB patient is from UP. So from the point of view of tuberculosis elimination, state assumes a lot of importance. The estimated incidence of tuberculosis in the state is 188 cases per lakh population. And prior to deployment of TrueNAT platforms, we were primarily dependent on the microscopy. Microscopy, which has reasonable specificity, but as far as the sensitivity is concerned, it is relatively on the lower side, and which leads to missing of cases. The case detection is slightly on the lower side, and moreover, the technical competence of the lab technician, it also plays a greater role in it. So to overcome these challenges, as well as the challenges posed by the comorbidity and some other operational challenges, this project was conceived. And this project covered 2 districts of the state. These are Sambal and Bahrain. Bahrain is one of the aspirational districts, one of the 8 aspirational districts in the state. A district which has a large geographical area, the challenging areas also, got a forest and borders Nepal. Another district chosen for this project was the Sambal. Sambal is a newly carved out district that used to be a part of district Muradabad earlier, an industrial town, this predominantly industrial district. Sambal has been carved out from that Muradabad. So these 2 districts were chosen. Are we getting slides, Dr. Shikha?
Dr. Gupta, I think there's a little bit of a technical issue.
No problem. Then I can
continue
without the slides also. So there was need to have an ecosystem where we can diagnose our cases appropriately and within the shortest possible time, and initiate the treatment, initiate those diagnosed patients on appropriate regimen as early as possible. So this was the challenge, and the objective of this project were to demonstrate how TrueNet, a molecular diagnostic platform, can expedite diagnosing the cases, tuberculosis cases, and detection of rifampicin resistance among these cases, and that too in the shortest possible time, as well as the ease of performance and the TAT, turnaround time. These were the objectives, how to do this in the shortest possible time. So 5 sites across 2 districts were chosen. 2 sites were in district Sambhal, and the 3 were chosen in district Bahraich. And the methodology and the design, I'm skipping these aspects. I will be coming straight way to the conclusions. In totality, 2000 plus samples, 2000 precisely 2019 samples were tested on TrueNet platforms. All those patients who came out to be positive on MTB step 1, they were tested for rifampicin resistance. 2% rifampicin resistance was detected, and 2% rifampicin resistance out of 770 MTB positives, they were detected, and about 56% of the patients could be initiated on the treatment same day. So the turnaround time was very much reduced, and this clearly emerged as the point of care molecular diagnostic platform. So this was the outcome of this study, and we have the slides. So we can move ahead. Can we have next slide, please? Anyway, yes, challenges by and large I have already listed. Goals, objectives have already been discussed. Next, please. Yes. So as I mentioned that we had 5 intervention sites. 2 were in district Sambhal. The Sambhal is located in the western part of the state, and 3 sites were located in district Bahraich. And these were the far-flung sites from the district headquarters. 2 were at a relatively larger distance from the district headquarters. And the sites, while selecting the slides, the care was taken that the sub-district level facilities with high footfall were listed. And out of them, the district level DMCs, CBNet sites, and the existing TrueNet facilities were excluded. Next, please. Next slide, please. Yes, this slide shows the design and the methodology. The consultation, this was the location of the sites was in consultation with the state and the project authorities, and trainings were done. Installation of TrueNet machines were done, and sample receiving, sample and the treatment initiation, all these things where the detailed SOPs were made, and the careful selection of site and the adherence to the SOPs that facilitated the smooth operationalization of the project. Next, please. So I was talking about the results. So in total, 2019 samples were tested for TB on TrueNet. and 100% MTB positive, those 770 were MTB positive. They were tested for rifampicin resistance, and the RIF resistance was encountered in 2% of the cases. 56% of the patient could be initiated on the very first day, and the remaining could be initiated within 1 week. Turnaround time was reduced as around to 92% of the samples were tested and reported same day. Earlier, it used to take time because the samples were transported to some other linked NAT site, and significant time was wasted in it. And even up to the lag was for 4 or 5 days to up to 7 days, this lag was there, because we were not having much NAT platforms also. But here the NAT platform was available at the very PHC or CHC. So the results were quickly available and the patient could be put on the appropriate regimen same day. And this really helped a lot, and the TrueNAT emerged as the point of care equipment. One of the limitation was certainly there, and that was the additional responsibility were assigned to lab technicians some due to COVID-19 waves. So this was a challenge, but despite this challenge, the project did well. Next, please. Next. Some of the key insights and suggestions for future. These are that the TrueNAT showed promising results. Training of LTs is certainly an important step for getting quality work done using these platforms and find wider adoption and scale up. Challenges were there, some breakdowns were there, but the MolBio team was quick to respond to the calls made from the field. And these 5 sites, they continue to support the state even after completion of the project. In fact, these machines have been donated to the state, and we have redeployed them as per our requirement. We are in the process of redeploying them, and based on these learnings, the state has expanded its its NAT network, and right now we are having 458 TrueNAT platforms across the state in over and about the CBNAT platforms. We have significant number of CBNAT platforms, but they have been our capacity has really been augmented by inclusion of 458 TrueNAT platforms. So this project clearly demonstrated the benefit which we get out of establishing the NAT platform at point of care. That was all from my side. Thank you very much for patient listening.
Thank you so much, Dr. Santosh, for an excellent presentation and for bringing out the success and limitations of the pilot. So we feel that the pilot, the introduction of TrueNAT, has supported taking TB diagnostic to the last mile in these districts, and the stage has been set for getting a confirmed TB diagnosis, say at the first or the initial patient visits. The study also showed that the lab clinical interface was strengthened, the turnaround time was decreased, and patients could be initiated early on treatment. So, sir, thank you so much for bringing out these learnings. And based on this, we can also look forward to same-day diagnosis and treatment initiation to impact TB elimination in India. And we are also happy to learn that you are on the right path to scale up and maintain the sustainability and the gains achieved from the project by deploying and utilizing these TrueNAT machines efficiently. So thank you so much, sir, for your time and your valuable contribution and the success of the project that we owe it to you. Thank you so much, sir.
Thank you very much.
Now I go back to Jaita. So Jaita, over to you, please, for the end note and the conclusions.
Thank you. Thank you, Dr. Shikha, and thanks to all the panelists from both the sessions, practically for setting the tone for future action and emphasizing on the urgency and the need for innovations and scaling these. I would heartily like to thank large number of participants who actively shared their comments and questions. And as I said earlier, we will come back to you with the responses from the panelists and look forward to stay engaged with you. Going forward, we will be using these insights and learnings from all the panelists, especially from also the last panel that we heard from this gathering, to inform future initiatives and programs. We did learn that there are some critical aspects. One, that the need for keeping the pipeline of screening and diagnostic tools and solutions are very critical at this point in time. Dr. Nishant very rightly, emphasized on the historical evolution of case finding, achievements and challenges, and the readiness to embrace new technology, which is very, very encouraging for all of us. We did hear that Dr. Pai emphasized on the potential areas of innovations. And from Dr. Serene, we heard about the disruptive technologies all in the pipeline. And of course, Professor Paul Alvani emphasized on the human-centered design thinking, very critical for training and knowledge sharing with the large health workforce that we have. And last but not the least, very critical, Dr. Kela did emphasize on the role of private-public partnership and how this could influence future upscaling of innovations and also in designing robust supply chain for service delivery. On the other hand, we heard from the two case studies, one from Mumbai, from Dr. Mangla Gumare, and we also heard from Dr. Santosh Gupta from UP, the true potential of TrueNAT as an indigenous product. So it's very, very clear that while there are new innovations in the pipeline, and we have also seen how new innovations can be disruptive in scaling up testing and saving many more lives for TB. And we need to all come together for that. And we will keep continuing this kind of engagement and partnerships in future. It's very important that we not only highlight the advantages of new technologies, but also learn from what is not working or what needs to be further improved in terms of taking solutions to the last mile, because that's where our communities are, that's where patients are. So I would like to conclude by saying is that, yes, we need new innovations, but at the same time, the innovations which are already there, for example, like TrueNAT, how can we scale this up in a large part of this country, and how the learnings coming out of these such new innovations can be spread across other lower and middle income countries. But in order to do this, it's very important that we have smart partnerships. And the two examples that we heard today are reflecting on this fact that smart partnerships work, and if we partner with government, there is definitely a road paved for further scale and sustainability. But in order to do all of this, we need resources, and resources are absolutely critical for ensuring that TB care continuum is successfully continued and achieved. And along with this, we definitely need to continue generating more and more and more evidence. So yes, with that, I would like to conclude and thank you all for joining this webinar. And we do look forward to keep our engagement with you in future. And with that, I would like to close this webinar and thank you all once again. We look forward to the next webinar in this series. So on behalf of India Health Fund, Find and Empower School of Health, I really thank all of you for joining. Stay tuned for the next one. Take care, all of you.